Good evening, everyone. Welcome to our sixth and last Zoom platform meeting to mark June Lipoedema Awareness Month. This event is a joint event by our Global Lipoedema Awareness Group and the Association Maladie du Lipoedème France. Ophélie Boudon, chair of the association, and myself will co-chair the event tonight. And our guest speaker is Dr. Burgos de la Obra from Spain, based in Madrid, who tonight will cover various topics, amongst them WAL liposuction from consultation to surgery, impact of lipoedema on the quality of life, the road from diagnosis evaluation to surgery. Lipoedema is a medical condition, and surgery's main goal is pain relief and improvement of quality of life. Thank you, Dr. Burgos, for accepting our invitation to support our awareness campaign. We look forward to learn more in the next 1.5 to 2 hours. The Global Lipoedema Awareness Group has a strong membership of over 9,300 members from around 100 countries. It is a pure global group where cultures with a shared word, lipoedema, meet and support each other. Since its creation in May 2016, the global group, over a period of 4 years, hard work, created the only global lipoedema surgeons list, which exists today with over 180 doctors worldwide. Our membership, we have albums from these doctors, more than 100 doctors, from operated ladies, and these albums help the ladies to see how the works of the doctor can help them ease the pain and lead where a lipoedema-free life where possible. Co-hosting the event with us tonight is Patricia Ruiz Lopez and Teresa Rentagoco, who will help us with your questions in English, French, Spanish, and Italian. Last but not least, our warm thanks go to the administrators of the two groups, Mia Jackson, Julianne Macy, Maureen McCartney, Lisa Lehrer-Dixon, Patricia Ruiz Lopez, Teresa Rentagoco, Danai Pancho, Nathalie Spenlet, Elodie Sauvageau, and Cécile Zalteni-Puchetti for their volunteer work and support to our lipoedema community globally. In addition, our warmest thanks to all of you who are here with us tonight. Neither Ophélie nor myself have any financial benefits from our groups. We simply have both the same passion to help our lipoedema community globally. Tonight, we also welcome Dalibor Svek, Managing Director of Lipoelastic UK. Thank you, Dalibor, for supporting our group with special offers. We know compression is a very important element of any pre and post surgery. Kate Foster, board member of Lipoedema UK. Sarah Suder Naramore, owner of Lipedema Sisters USA, and many administrators and from various groups. Tonight's event is also live in the Global Lipoedema Awareness Group. You are all welcome to write your questions there under the live video or in the chat area in our meeting here. I would like to invite Ophélie to say a few words about their association. Ophélie, the floor is yours.
Thanks, Maria. Donc, je vais dire quelques mots en français au nom de l'association française. Donc, je remercie Maria tout d'abord pour son soutien et de nous avoir conviés aujourd'hui à cet événement pour mettre à l'honneur notre maladie durant ce mois du Lipoedème, donc ce mois de juin, avec le support du groupe mondial Lipedema Awareness. Un grand merci également au docteur Burgos qui est l'invité de ce soir et qui va nous apporter des éléments de réponse, je l'espère et j'en suis persuadée, sur les thématiques énoncées par Maria, donc à savoir la liposuction par la méthode WAL, l'impact du lipodème sur la qualité de la vie, le cheminement du diagnostic jusqu'aux opérations et les améliorations possibles avec les opérations. Donc avant de commencer et de vous laisser avec le docteur Burgos, Je vais vous dire quelques mots sur l'association française Maladie du Lipoedème France que je représente aujourd'hui. Je suis la fondatrice de cette association qui a été créée en novembre 2019 et qui a pour mission de soutenir les patientes et d'approfondir les recherches sur le lipodème. Pour les Françaises qui sont là, vous le savez certainement, le lipodème en France est une découverte plutôt récente, malheureusement. C'est pourquoi nous travaillons avec l'association sur l'obtention de la reconnaissance de la maladie, à travers notamment la sensibilisation, l'information et l'accompagnement des patientes, des proches et des professionnels de santé. Pour cela, on a créé une page Facebook appelée Association Maladie du Lipoedème France, sur laquelle vous pourrez retrouver des informations sur la maladie, sur les différents traitements, qu'ils soient conservateurs ou curatifs, sur les procédures administratives en France, sur les droits des patientes ou encore des listes de médecins pouvant vous diagnostiquer ou vous opérer du lipodème. On a également un compte Instagram qui est appelé Asso Lipoedème France que vous pourrez retrouver. Et on vous invite aussi fortement à rejoindre la page Facebook Lipedema groupe de soutien francophone. C'est une page qui est exclusivement réservée aux femmes qui sont atteintes ou qui soupçonnent d'être atteintes de la maladie, qui recense des témoignages, du partage, des échanges, beaucoup de bienveillance et du soutien. On organise un congrès le samedi 10 octobre 2020 à Paris pour une journée de sensibilisation sur le lipodème, auquel on aura l'honneur de recevoir le docteur Burgos, que nous remercions fortement d'ailleurs d'avoir accepté notre invitation et de sa confiance. Et puis, pour terminer, vous pourrez retrouver toutes les informations sur le congrès ou sur la maladie en France sur notre page Facebook. On remercie tous les membres qui nous suivent, les professionnels qui nous font confiance et nous soutiennent, ainsi que les adhérentes. Je tiens particulièrement aussi à remercier les filles qui travaillent avec moi à la tête de l'association. Un grand merci au docteur Burgos et à Maria de nous faire partager ce moment tout ensemble. Et je vais vous laisser savourer ce moment. Merci beaucoup, Maria.
Merci, Elodie.
Oh, taisez-vous!
Mais qui est celui-là qui fait ça? Oui, alors, on essaie. Oui, on va continuer un instant, s'il vous plaît. Vous voyez le CV de Dr. Burgos là?
Oui.
Oui. Alors, it is my great pleasure to present Dr. Burgos de la Obra. Of course, Dr. Burgos has not only an impressive CV, but a huge experience within this CV. Is so many things to say. Allow me to spot some things that I chosen for today's event, Dr. Burgos. Dr. Burgos de la Obra is the medical director and chief surgeon of Lip Medical and was the first Spanish doctor to devote himself exclusively to lipoedema treatment using and developing the WAL technique. Dr. Burgos firmly believes that lipedema should be approached as a medical problem and not as a purely aesthetic condition. Dr. Burgos holds a medical degree from the Autonomous University of Madrid, attended various trainings, amongst them in general surgery and liver transplantation and advanced oncological laparoscopic surgery. Very impressive, Dr. Burgos. It's very complicated. He holds a master in aesthetical medicine from Complutense University of Madrid. In his professional career, Dr. Burgos worked in many hospitals as a general surgeon, collaborated with aesthetic clinics, was a visiting lecturer at the Universidad Complutense in Madrid and the University of São Paulo, CEU. In addition, he did medical, surgical volunteer work in Cameroon and Calcutta. He received his training in WAL surgeries in Berlin, in Germany. And lastly, he was awarded the Sanitas Award for the best contribution in clinical research for importing the WAL technique for lipoedema in Spain. Dr. Burgos, the floor is yours. We welcome you and thank you very much. We are eager to hear what you have to say to us tonight. Thank you very much.
Thank you, Maria. Thank you, all the participants to be here. Thank you, the French Association of Lipedema, to invite me to their Congress and to be here as well. Well, when at first Maria asked me to do to participate on this activity, I first thought about doing like a very shiny presentation with a lot of before and afters and so on. But then I realized that part of the message will be lost. And what is important I want to transmit is that lipedema problem is mainly seen by almost all of the doctors as an aesthetic condition. And I firmly believe it's a medical problem with plenty of medical consequences that we are going to speak about. So I'm going to try to use as a thread the moment the patient arrives to the consultation, and we're going to follow her onto this like process of getting a diagnosis, going to surgery, doing the follow-up to see how everything changes throughout all this process. All right. So first, when a patient arrives to our consultation, the first stage is very similar to any other medical consultations. We ask her about previous allergies, previous medical conditions. We insist a lot in knowing if she has any kind of prothrombotic or coagulation problem, if they have had any cardiac or severe pulmonary issues, and we ask about all the previous surgeries they had. Very frequently, we find that many of the patients that arrive to our consultation, they have previous liposuctions, sometimes 1, sometimes 2, sometimes even 7. So we really need to know more about what was done in those liposuctions, when were done, which areas were addressed, which technique was it used, what was the result in terms of aesthetic improvement, but also in terms of medical improvement. We frequently see that most of these liposuctions were insufficient in treating the medical symptoms. All right. So we want to know more about how many members of her family have some similar condition, and it seems that this comes more from the father area than compared with the mother area, and it's surprisingly often that they have cousins, they have aunts with this situation, and we want to know about that because there are many conservative measures that they can tell them so they can do them and improve as well. We want to know when did they start to feel that the legs were different. We know that the lipedema condition has an important hormonal influence. So that's why usually this starts in the puberty or intensifies with an hormonal treatment or a pregnancy or menopause. So those are little things that get us closer to know more about how this developed and when did it intensify, when did it got like worse. We make like a very thorough questions about all the specific symptoms. We need to know that lipedema can be very, very, very symptomatic or have just very, very slight symptoms. On the first stages, the symptoms most described is like some sort of heaviness, some sort of tenderness. But as this condition progresses, this can cause pain, discomfort, like when somebody touches the patient, they really jump. So they start to develop a fear to be touched. And for example, with mothers, when the children step on their legs, they really feel very sore, and that is not normal. One thing that happens with lipedema patients is that they've been with symptoms almost all their life. So they start assuming that those symptoms are normal. So they feel that it's normal that after doing sports, the legs get swollen, that day they're gonna have to raise their legs because of the pain. They start to feel that that happens to everybody, but it's not. That's not true. So we really need to put that into light, that those symptoms are not normal. Also, additionally to this, there's some psychological problems related to lipedema. It can be very mild, but can also very intense. I would say that up to 15% of the patients we see at consultation, they have or they have had psychological issues such as depression, anxiety, eating disorders, difficulty in managing social relationships, even influencing their sexual, the sexual aspect, the way they relate to others. And this needs to be asked, because many times we assume that lipedema symptoms are just physical, and lipedema symptoms are very also emotional, because one part of the problem is the complete loss of the anatomical shape. Usually the patient, they lose the shape of the knee, of the ankle. They have even some difficulties to walk with normality, because it's frequent that the fat in the inner thighs has some friction, makes some friction with each other, and that even makes the patient to have more like joint problems, knee problems, ankle problems. And we really need to be aware of this in order to evaluate what is going to be the impact of our treatment. So it's very important to determine what is the impact in the day-to-day activities of the patient. Is it just a very mild affectation, or is it a very deep impact? Some patients, they even have some difficulties in sleeping. Like they can, if that day they have had like a match of like a tennis match or something, they are not able to sleep. This is a very important symptom, but very frequently they think, well, it might be normal. All right. We need to know a lot about which kind of measures have they tried. Many of the patients, they have tried compression garment, and many of those patients that have tried compression garment, they feel that this didn't work, or it was very uncomfortable, or it was like very uncomfortable behind the knee, on the ankle. That's because many times the hosiery that they're using is circular fabric. It's not a flat knit fabric. The flat knit fabric is much more adaptable to the shape, and it really acts as if the patient was receiving a manual lymphatic drainage. Many times the patient have tried a manual lymphatic drainage, MLD, and most of the times they feel that this massage, they provide some relief, but it's very temporary. Maybe they have the massage today, but maybe in 2-3 days, the symptoms start to appear again. Once we've spoken about all the symptoms, we go to the physical examination. What we have to look at in the physical examination, first, it's very frequent that there's a disproportion between the torso, the chest, the belly, and the legs, or sometimes the arms. Sometimes it really feels that there's one body from the waist up and a different body from the waist down. The fat above the quadriceps very frequently falls onto the knee, and the knee loses its anatomical shape. The lower leg starts to acquire a cylindrical columnar shape. But it's very important we know that feet are free of affectation, which is that this feature makes it very different from other conditions such as lymphedema. So feet are free, and just above the ankle is when this affectation starts. The affectation is most of the times symmetrical, and when, for example, when we ask the patient to step on the toes, we cannot see the muscle, because the muscle is there, but it's covered with a layer of fat. It's important to do a differential diagnosis with other conditions such as obesity or lymphedema. Obesity and overweight sometimes coexist, and that makes also the diagnosis sometimes a little bit challenging. We're going to speak about more about that in a while. So about lymphedema, we would see that there's an asymmetry, an affectation which is mostly liquid because of the impairment of the functioning of the lymphatic vessels. So the affectation is going to fall onto the knee, and that's why we are not going to be able to pinch the feet in between the fingers, which what is called in a stemmer positive sign. And also in obesity, we see that the distribution of fat is more global. Obesity isn't painful. We really need to know about this. Normal fat is not painful. When you pinch your fat is painful, there might be another problem, which could be lipedema. So, and obesity tends to respond to exercise or diet. We receive many patients that during parts of their life, they've done a lot of exercise, and they start to feel very, like the face gets very thin. The ribs can be seen, the collarbones, but the legs, they don't change that much, all right? Okay, so with this examination and with this anamnesis, we reach a diagnosis, and we classify the lipedema the patient has in different grades and different types. Grades refers of how much it is, types is where it is, right? I want to stop now in this moment, the diagnosis moment. Like, for many years, the patient has felt guilt, anger, frustration. Just to receive a diagnosis is very therapeutic. It really relieves the patient from all these previous feelings. And we need to know that we don't need any special machine, any special equipment to diagnose this. We just need to speak with the patient and to do a physical examination. So this diagnosis is very accessible to all the doctors. So the main problem in lipedema, in the lipedema world, is the lack of diagnosis. We really need to educate all the GPs, the vascular surgeons, the internal medical doctors, because it's extremely easy to diagnose a typical case of lipedema. I can agree that some early stages one can be tricky. I can agree that sometimes there's obesity or overweight that coexist with lipedema, but most of the cases, they're really easy to diagnose. So that's why I feel it's very important we keep raising awareness, and it's very important the job you're all doing, trying to speak about this. We need that the television speak about this, that the politicians speak about this. This past month, Lipedema month, I sent emails to all the main Spanish televisions to speak about lipedema, concerning lipedema month. I got no reply, but this little by little, I think it's going to be changed. And also we need to know what are the consequences of a lack of diagnosis. If a patient stays 20, 30, 40 years without diagnosis, this is like putting stones in a backpack, which is frustration and guilt and depression, and this grows and grows and grows. So it's key that we need to find an early diagnosis in most of the cases. When we reach a diagnosis, we start with the explanation of what can we do to treat this condition. So there are two main options. There's conservative treatment or surgical treatment, but in my opinion, both should be done, well, at least conservative, but when we do surgical, we don't need to forget about the conservative treatment. So the conservative treatment has three main pillars. First, the use of compression. In my opinion, it has to be lymphatic compression type 2, in France is type 3, and it has to be flat knit, has to be tailor-made, because it's very frequent that when the patient, they get like sizes, this hosiery adjusts good in one area, but not good in another area. And this compression can reduce the pain up to 30-40%, which is a huge impact. and this could be prescribed by the GP. So it's very important that we know, all the GPs know about this. But the thing is that using this compression for the rest of your life is something has a lot to do with where you live. Like, for example, when we receive patients from Canada or from Sweden, it's going to be much easier for them to wear this compared with a patient that lives in Saudi Arabia or in Brazil. Because if you live in a country where above like 4 or 5 months of the year, the temperature is above 35 degrees, it's going to be very difficult that you keep using this. So that's one of the restrictions that, or the elements we need to know about this. The second thing is about sports. Patients with lipedema very frequently, they don't do sports because they feel they have a weight in each of the legs. There's some friction in the inner part of the thighs, and they enter a very negative circle. So I do sports, I feel sore, I feel heavy. I don't do sports, then I get more volume. Then I don't even think about doing more sports. So it's a negative circle that makes this grow and get worse. And third pillar of conservative treatment is the anti-inflammatory nutrition. I don't know if many surgeons are aware of this, but I really see an impact when the patient start to avoid gluten, avoid lactose, avoid processed food, and they start to eat more nuts, berries, bluefish. It's not really clear how this works, but the patient needs to know that there's a possibility that can improve their symptoms. So that's why I'll always recommend them to try it to see if it works for them. So this conservative approach can even make that the patient doesn't need surgery. Sometimes in early stages, it can be controlled with this conservative treatment. So going to a consultation of a lipedema surgeon doesn't have to mean to go to surgery. In my opinion, it's very important we all know about these conservative options, and I encourage all of the patients with lipedema to try them before making the decision to go for surgery. If we have doubt or not that the patient needs surgery, it's better to wait 4-6 months to see how this conservative treatment acts and what's the reaction to the patient to this treatment. All right, so let's say the patient would like to go for surgery because he has tried conservative treatment, or because their symptoms are too intense, or she lives in a very hot country. So we are going to explain about all the details of the surgery. What are the risks? What are the objectives? What can she expect from the surgery? We have two types of objective. One is to control the medical symptoms, and the other one is to control or to improve the shape, which has a lot of relation with the emotional symptoms. Main goal of treating the symptoms is to stop the pain, to reduce it or to make it disappear, depending on the case. We need that the patient feels lightness, that when she does sports, she doesn't feel that there's consequences of doing sports, that we need her to change the way of thinking about sports. It has to be something positive, not something negative. We need to know, we need to stop the progression, control the progression, reset the situation. We still are not sure about in what degree we are stopping the progression, but for sure, when we are removing 25 liters of the legs of one patient, we're really making a change. And also from the shape point of view, when the patients with lipedema, they unconsciously hide their legs. When they are in the photographs, they always are on the back. When they are wearing dress, they wear dress to the ankles. When somebody asks them to go to the beach, they prefer not to go. So we need to change that. And sometimes it's not easy, like, because I had patients that after surgery, the legs, they have completely different shape, but they still feel vulnerable. They say that when they are wearing short pants, they still feel naked. So it's a process that the patient needs to acquire, but it's very important that we try to find, we try to look for a reshape of the legs, but nothing else to recover the anatomical shape, to recover the shape of the knee, to recover the shape of the ankle, to get a natural curve of the hip. One part of that result depends on what the surgeon does. Another part is true that depends on the reaction of the patient to the surgery. It's very different when we operate stage 3, when we reduce this volume to this volume, compared with the stage 1, which is like less volume is required to be removed. Or it's different when we operate on a patient which is 25 years old compared with a patient which is 55 years old. But in every single case, we need to fight to reach the best possible result. Like, it doesn't matter the age, doesn't matter the grade. We need to try to get to that point where like the result is at least the better possible for that patient. Sometimes if the patient has had previous surgeries, previous liposuctions, the surgery can be a little bit more intense with a more tiring post-operative period. And sometimes we need to add a technique which is called lipofilling. Lipofilling means to transfer fat from one area, a donor area, to another area that has like a deficit of less volume. So sometimes when, especially in old liposuctions, when we see holes, like deep holes, this needs to be improved by transferring fat from one area to the other one. Part of the consultation is also for the relative, for the person who's going to be there after the post-operative period. It's very important that my advice is that the patient, they come to the consultation with that relative that is going to be there taking care of them. I have operate relatives of mine, and I have had that role of the person who's giving care, and it's very important that that person is aware of what's going to happen, that this is a medical condition. Sometimes even the husband, they really don't believe that this is a medical condition. So it's important that they come to the consultation, they get all the information, and they are also part of the process. So once we've explained all the details of the surgery, then we draft a plan. The plan can consist in just conservative treatment, maybe conservative treatment and see us each other in 6 months, or going directly for surgery, or maybe doing a preoperative loss of weight before going to surgery. It's very frequent that the patient with lipedema has overweight. So the less volume they can bring to the operation, the better. But it's also true that sometimes it seems that there's like a wall in which you cannot go past that wall, and you lose volume, and the legs don't change that much. So it's something that the patient needs to try. My advice is always, if the patient is in an overweight situation, to try to find some nutritional advice. And sometimes if there's like these psychological issues, maybe some psychological advice as well. It's good to have someone to speak with about what you feel, about this frustration, about all these years of guilt. It's very positive to know about that. All right, so we set the treatment plan, we draft the treatment plan, and one thing I want to highlight is that lipedema surgery is not urgent. So many patients, when they get the diagnosis, they try to rush into surgery. Can I have surgery tomorrow? It's very, very important we think about it slowly. Like, get the diagnosis, it's a lot of information. You breathe, you think it thoroughly. It's not going to be that difference if a patient has the surgery today, in 6 months, in 1 year. Nothing's going to listen. This is not like a tumor that if you leave it, it gets really, really worse. So my advice is to make like a slow decision, to speak it with your family. It's a very important decision in a women's life. So don't rush into surgery, and try to just breathe and evaluate all the elements, evaluate what does it mean to have, what does it mean lipedema in your daily life. Lipedema surgery is not just a very an economical effort. It's just an economical, a familiar, a professional effort, because sometimes there's more than one surgery program. So my advice is just think it thoroughly. Just a small notions about WAL Lipedema surgery. WAL Lipedema surgery, it works by instillating pressurized saline solution at the same time you are aspirating. So this, in my opinion, it allows the surgeon to be much more delicate and much more achieve much more details. So when some surgeons, of course, they use Tumescent surgery. That's a safe surgery, but in my opinion, WAL liposuction gives you like an extra of details. It's true that the machine and the devices and the handpieces are more expensive, but this technique is much more gentle with the lymphatic vessels, with the nerves, with the blood vessels. So for me, it's a tool that that should be, that's an opinion, the standard of care of lipedema. I know there's other surgeons that use Vaser and so on with tumescence. My opinion is that for Vaser is fantastic for the abdomen, and for the legs, my preference is WAL. Please note that there's no evidence in this. This is like in the levels of evidence, the lowest levels is the expert opinion, and we still don't have any scientific article comparing these two techniques. But with WAL technique, as you infuse very small amount of volume, that means that you are able to control every area, infuse aspirates, and you do like a circumferential approach, with always in the axial, in a parallel sense, and it really improves the final result compared with other techniques, in my opinion, both for lower legs and for upper legs. I highlight this, that this is an opinion, and it's really not been proven scientifically. So let's say that the patient has decided for surgery, and she's going to, he has done the preoperative test needed, the PCR of the COVID and so on these days. So she arrives to the hospital the day of the surgery, and she always arrives with a mixture of emotion and nerves. So first part of our job is to come to the room, to talk to them quietly. This is not like very fast, you arrive at the hospital and the next minute you are in the operation room. We need to solve the last minute doubts. We need to speak with the relative to see if they have any questions. We're gonna do a very detailed preoperative marking. In this preoperative marking, we're gonna ask if the patient feels that there's some asymmetry in the volume, if there has been previous surgeries. Also, we want to know more about the preference of the patient. Some patients, for example, for the buttock area, they prefer like to leave it flat. Some of them, they prefer like more round shape. So we really need to take into account the patient preference to the shape, and also the preference of the patient to the amount of volume we want, how intensive she wants us to be. We speak with a relative. We tell them that the surgery is going to last from 3 to 3.5 hours. So we usually recommend them to go have breakfast, relax a little bit, and come back to the room maybe 2.5 hours later. We do a detailed checklist, and we review the allergies, the area that is going to be treated, the previous Doppler ultrasound, the previous blood test. We check everything again, and the patient is taken to the operation room. First, the pre-surgical area, where the anesthesiologist is going to come there and speak with her and know more about, like, really check again about the allergies and so on. We're going to enter the operation room. We need to know that the operation room is not as in the movies. It's not like a very stressful area with rush. No, it's very quiet. Everything is very calm. Everything is explained to the patient before we do it, so they don't get like like they are not surprised. We're gonna apply some antiseptic solution to the legs. It's a little bit cold sometimes, but on the contrary, the operation room bed is gonna be warm, and the anesthesiologist is going to take an IV access. Once he's going to start with some medication. All our surgeries are done under general anesthesia because we feel is the safest anesthesia for this procedure. And we're gonna start by opening the material and so on. And the patient, we always ask the patient to think about something relaxing, like a trip, a beach, walking on the beach, because it's been proven that the more calm you sleep, the better you're gonna wake up afterwards. So the surgery starts. There are two main phases for the surgery. There's a first phase in which we are progressively removing volume in an axial way, in a parallel way, but treating circumferentially all the leg. In that area, we're gonna try to get the fat very homogeneous. We're gonna make a lot of changes in the position of the patient, the side up, down, the side to the other side. That part is important, but the next part is more important, which is looking for the detail. And that is around, I would say, 30 or 40% of the operation in our case. We recheck and put in different positions and lift it and see if it's absolutely equal and recheck. Sometimes the anesthesiologists, they get a little bit desperate, but we don't care. We really feel that phase of the surgery is the key. So we don't leave any bumpy areas. We check that the knee has recovered fully the anatomical shape. We check the ankle. We put the patient to the side and see the curve. We are very maybe too much, but very intensively checking to see that the result, because that result has to be final. Our aim is that the area that has been treated should not be addressed again, or at least not in the next 15-20 years. That's our goal. It also, of course, depends on the case, but that's why we are very delicate in the checking of the details. All right. So once the patient has, once we finish, we're gonna put the compression garment on. Personally, I think that this is the most difficult part of the surgery. Like the patients, for you, it's difficult. For us, it's almost impossible. With the patient awake, it's like we have to turn it around and use at least 3-4 people. And then we're gonna put the self-adhesive bandages on top of that. We're gonna leave stitches open so it drains through those incisions, and the patient is going to slowly awake. The moment we are already bandaging, I tell the nurse to call the relative, so they know that the main part of the operation is over, so they can relax a little bit. And after the surgery, I will go personally, me or one of the surgeons of my team, will go personally to speak with them and tell all the details of the surgery. But it's important that the moment we're finishing the important part, the relative knows that the most important part is over. So the relative, the patient will then be taken to the recovery area, where she will be around 1 hour, 1 hour and a half, checking if there's no nausea, that she feels okay, that the pain is controlled, and then she will then be taken to the room. So we give very detailed instructions for the patient what to do that afternoon. Like the usual reaction of a patient that already has had lipedema surgery is to stand up to see her legs. That is very dangerous. So do not stand up directly. We will tell you get the operation, but first sit, stay 10 minutes. Then we're gonna put you on the chair around 1 hour, and then you stand up. You see how you feel. You sit again, like a golfer. You stand up again. All right. Then I can stand up and can try to walk. The patient needs to leave the hospital walking. It's not like a normal walk. It's more like a duck walk, but it's still the patient. If the patient doesn't walk, she cannot leave the hospital. Usually, it's 1 night stay. And the next day, we check again in the morning how the patient has slept. Usually not that good, because we're going to put a lot of fluids, and those fluids is going to make the patient to have a lot of urinating feelings. So that night is not good, neither for you, neither for the relative who's there. And before leaving, we're going to give a lot of instructions to especially to know what's normal and what's not normal in the post-operative period. So what's normal? It's normal to feel like swollen, to have like electricity feelings, like kind of pinching feelings. It's not normal to have like a temperature of 38. We need we give a very detailed explanation on what to expect and what not to expect, what to do with the compression. The compression needs to be worn in our opinion, from 3 to 6 months after surgery. This helps with the reabsorption of the edema and also with the recovery of the skin. Sometimes, in some cases, the reduction is huge. So what some patients do is that they go they get it sewed so that it can be adjusted. But this should be done maybe 3 weeks after surgery, because at first it's going to be very swollen. Just a small talk about when patient have overweight and at the same time have lipedema. So if you receive a patient who's like maybe 110 kilograms and they have lipedema, should we treat overweight first? Should we treat lipedema? Well, the thing is that overweight has a lot of influence in lipedema. So if the patient has reached that point when she cannot lose any more weight because of the lack of response of the legs of the lipedema cells, if we go for surgery and we remove a lot of volume from the legs, that's going to improve a lot the quality of life of the patient. It's going to improve a lot her ability to do sports, and she's going to enter a very positive circle in the sense that she's going to be able to do more sports, she's going to see results, she's not going to have pain, then she's going to want to do more sports, and so on and so on and so on. So it really there's a psychological change after surgery. It's not just the physical, it's also the psychological change of the motivation of like the situation after surgery, that it really changes. So the stitches are removed in 10 days, and usually we like to see the patients 3 months after and a year after. The problem is that around like 95% of our patients, they don't live in Madrid, and around 30–40% of our patients, they come from countries which are sometimes very distant. So if everything's fine and everything goes as expected, we don't ask the patient to come. If they come, fantastic, we're going to be there, but we don't ask them to come to see that everything's perfect. All right, so what changes after surgery? Well, many of you know about this, but like it looks like everything changes. Like the patient feels more confident. They feel they get rid of all that frustration. There's more ability to walk more, to run. Many patients with lipedema, they couldn't do like sports for many years. So there's like a reset of all the physical situation and also of the emotional situation. Many patients that take depression pills, they don't use them anymore. Many patients that even have diabetes, as they improve in the type 2 diabetes, they improve the ability to do sports, they lose volume in the central area. So it's like a complete improvement in many aspects of life. So that's why it's key that there's an early diagnosis. It's key that the surgery is ambitious, and we are trying to look for like the optimal result. I really see many patients that have had surgery and just a little bit of volume was removed. This can be helpful, but in my view, we need to be ambitious if we want to look for the long-term result. We really don't know how long is this long-term effect, but there's been some studies 12 years, 10 years, they say that the results they tend to maintain. I believe it's key to keep a healthy lifestyle, but we still don't know how it's going to be when the patient it's like 20 years from that moment. But at least our aim is to try to improve the situation, so we are at least try to look for that long-term effect. And that's like the main things I wanted to tell you, and I'm sure that there's going to be very interesting questions, and I would love to answer.
We finished, Dr. Burgos?
Yeah.
We have quite a, thank you very much. Last week we thought we will write a PhD. Today we will write a postdoctorate with our knowledge, going away from 6 prominent doctors. So thank you very much. We start the questions. As Patricia is not here yet, I will start the questions from the group. And we have the first question from a French lady who is asking, is about breastfeeding. Is it possible to be operated if you are breastfeeding for more than 2 years? And considering that there will be a break of a few days to take the anesthetic out of the system?
My advice is to operate outside hormonal changes. So I don't believe it's a good idea to have the operation while breastfeeding, because the breastfeeding has a lot of hormones in play. So my advice is to wait at least 3 months after finishing the breastfeeding.
Thank you very much. The second question, it says, is a statement and question. I have noticed in myself and many other lipoedema ladies that it goes hand in hand with ETS, joint, organ, skin hypermobility, and mast cell activation syndrome. How do you address these issues when you treat a lipoedema lady using liposuction and skin removal?
So first of all, I am super specialized in lipedema liposuction, therefore I don't do skin removal. I think I want to make this clear. Like, I believe that like modern medicine tends to go to super specialization. So the more focused you are in a procedure, and the more volume you do it, and you do it one day and the next day and the next day and the next day, the better are going to be the results. So my advice for skin removal lift would be to find an expert in skin lift. So I wanted to say that because it's important to make clear that I'm a super specialized in lipedema, liposuction of arms and legs. You were saying about the hypermobility. We see that it's very, very frequent. There's a Byton score, and it's very frequent that the patient have hypermobility that also has impact in the joints. For example, I think that many patients, they have this X leg shape because of that, a combination of the weight, the friction in the inner thighs, and also that hypermobility. And we find that there's no problem in operating on a patient that has hypermobility. We find that the postoperative is more or less the same.
Thank you very much. The third question is again from a French lady. Is there an age limit that you operate?
We really need to balance between risk and benefit. There's no like an age when one day after you don't operate. You really need to balance, and also what is the health condition of the patient. In our case, we remove big volumes, sometimes up to 10% of the body weight. So any wall liposuction, which implies high volume, has a great impact in the circulatory system. So we really need to assess not only the age, but also the health condition of the patient to be treated.
Teresa?
Yes, thank you very much, Dr. Burgos. Very interesting to hear this. I will take the questions from our chat here in the Zoom, and I will start with the question, how likely is it that the swelling and pain continue?
I cannot hear you.
Teresa, we can't hear you. Let me, yeah. Teresa, you're frozen.
Hello.
Yeah,
Typical. Yeah, my internet just. So I take it again. Sorry for that. How likely is it that the swelling and pain continues after surgery? Is it related to how far gone the symptoms are?
All right. So about swelling, we really need to check this is not a lymphedema. If there's doubt of that this is a lymphedema, we need to assess the situation with a lymphography. Concerning the swelling that goes just to the ankle, this is very frequently found in patients with lipedema. And the general situation is that it's that there's a very big improvement in this swelling. We don't always completely eliminate that swelling because it can have some relation with vascular circulation as well. But we really see that by relieving the pressure, there's a very important improvement in the swelling. But we need to know that the swelling can last for 3 to 8 months, sometimes 9 months after surgery, especially on the ankle area.
Okay, thank you. And the second question, is the recovery process related to how far you are in the illness?
So to how far what?
To what stage you are in the
Of course, the more volume you remove, the harder it's going to be the post-operative period. But this is not always like this. Like the recovery has a very personal factor. Sometimes we operate sisters, more or less same volume. One of them recovers very fast. The other takes more time. The skin is like a little bit more flaccid. So it really has a personal aspect. We usually recommend to have a sick leave of 2 to 3 weeks after surgery, depending also on the work of the job of the patient. So for example, a waitress, maybe she needs 1 month, but if you want to telework, maybe 10 days it's enough.
Okay, thank you. And the third question, how do you know that you took enough fat during the surgery? And how do you know? Do you feel with the hands or by the look?
Of course, yeah. Indeed. We are using one hand to use the cannula, and with the other we are pinching and controlling perfectly where the cannula is. And at the last part, we are just by pinching, we are controlling the precise volume that it needs to be left. We cannot remove all the fat. We cannot leave like the skin and the muscle like this. We need to leave a small layer so it provides shape and it provides protection and the normal functioning of the fat.
Okay, thank you.
From the group now, we have a question. Why do you recommend flat knee compression over other type of compression?
Because the flat knee, the way it acts is not elastic, it's very firm, and that when the patient is moving, it really feels the same as if you were receiving a massage. The circular fabric, the other kinds of fabric, sometimes they bend and they hurt behind the knee or in the ankle. So it really helps to have a flattening fabric, which has to be also tailor-made.
Another one is, when there is obesity, it can often be attributable to Hashimoto's, MCAs, and ETS. This cannot be dieted away too. It requires a multidiscipline doctors to talk to each other, give treatments in the areas or endocrine, rheumatology, vascular, and immunology. How can we make this happen? It seems insurmountable.
When there's obesity, we really need to consider which grade of obesity this is. So very advanced obesity, I think that liposuction is not the best approach. The best approach is, as she says, a multidisciplinary approach where there's coming into play an endocrinologist and also maybe a bariatric surgeon. So when there's like central obesity, the first step is never liposuction. The first step is endocrinologist, evaluation via bariatric surgery. But some cases that they have lipedema plus overweight and like not that advanced obesity, they may benefit from the liposuction, because there's going to be it's going to allow them to move much better and to lose weight much better.
The third one is, does Dr. Burgos use Renuvion to help with the skin texture?
Well, there are different techniques of trying to tighten the skin. There's body tight, there's laser, there's Renuvion. My belief is that at the same procedure, you are already asking a lot of effort for the skin. The skin suffers a little bit. So when you are providing a device that puts some heat in that area, it feels that it might be a little bit delicate, and I think that it won't be the best idea to do it at the same time. It seems that Renuvion has some safety advantages, but still it's a procedure which is very new. So there's not that much experience on the long term of the effects about this. We also need to know that the skin recovery capacity is huge, and sometimes what 3 months after surgery seems that this patient is going to need procedures, lift, and so on. A year after, the skin has keep recovering, and no procedure is needed. So my advice is to wait at least 1 year to see the final results. Renuvion also, it adds time to the surgery, and it adds, like, it's more expensive. Sometimes I think it varies from 1,000 euro, 2,000 euro more. So my advice is not to, like, maybe if used, to use it as a secondary procedure if needed. So do the surgery, do the thighs, and after 1 year, see if you need Renuvion, if you need a lift. But I'm not very fond of using these techniques at the same time of the surgery because of these reasons.
Teresa?
Yes, and you were talking about fat transfer as well.
Yep.
And there's always this discussion about the lipedema fat, if it's different from others. So when you do the fat transfer, which fat are you using?
When we do the fat transfer, there are some studies that, because one thing which is very important of fat transfer is the survival of the fat that you are transferring. So there are some studies that, like, when you transfer fat, never the 100% of the fat is going to survive. It usually goes from 70–80%, all right? But when you're using lipedema fat, it's around 50% of survival. So my advice is to use fat from the flanks or from the belly, although there's some doubts that there might be lipedema in those areas, but at least try not to use very clear lipedematous fat.
Okay, thank you. So at your clinic, is it guaranteed that you will do the surgery, or could it be done by someone else in your team?
All right. So we are 5 surgeons on the team, and the patient decides which is her surgeon. All right. If she has if he has the consultation with another surgeon and wants to have surgery with that surgeon, that's fine. She will have with that surgeon. If she has consultation with that surgeon and makes the diagnosis and wants to have surgery with me, the patient decides and will have the surgery with me. The thing is, or if she has a consultation with me and wants to have surgery with me, she can have it with me, of course. The only thing is that the waiting list for myself, it's a little bit longer than with the surgeons of my team. I don't really know why, because we do the same surgery with the same technique. The results are very similar. It's also the social media, they do a lot, and sometimes if they just want me to do that case, but I prefer to do the more complex cases where you have to transfer fat, or there have been 4 or 5 previous liposuction. I do all kind of cases. But of course, if the patient wants me to have surgery, It's not that I'm going to be in another place. If that day, I don't know, my mother is sick or I'm sick, and we see and we tell, we have the option that this surgery can be done by a surgeon, but it has to be something like very, very special, very urgent.
Okay, so that's good to know. So so everyone in your team are specializing in lipedema as well,
yeah.
or?
Yeah, that's right.
Okay, great.
We only in Lipe Medical, we only do Lipedema surgery. We don't do any other procedures, no tummy tuck, no breast surgery, just liposuction of Lipedema.
Okay, great. And then the third question, and that is about the general anesthesia. Yeah. If you could comment a bit on the side effects, and also if a patient needs several surgeries within a period, what are the risks of receiving general anesthesia?
All right. From my point of view, the general anesthesia is the safest anesthesia because you have a perfect control of the airway. Everything is, all the parameters are very well controlled. And also the general anesthesia requires some infrastructure. I think like some doctors, they use twilight anesthesia, but there's less control of the airway. From my point of view, it's a little bit uncomfortable for the patient to know about the situation, to ask her to turn on the side, to be aware. Sometimes I have patients that have had twilight anesthesia and they don't want to hear about that. And the risk, it's individualized. So that has to be evaluated by an anesthesiologist, which is a professional who assesses this risk. But most commonly for patients below 60 years old with no previous important conditions, I think it's very, very, very safe. And it doesn't matter. Of course, the risk every time you go to the operation room, you have another anesthesia. But I think that we still haven't had any issues with the general anesthesia so far. When we do different procedures, in our case, we wait 8 weeks, 2 months from one procedure to the next one, because we've seen that that's the perfect timing. So the blood tests recover perfectly. The patient gets strength again. So more or less, the moment the patient is going to get strength, we get the operation again. So because I heard that some surgeons wait 4 months, 5 months, but in our opinion, that makes the process very long, and it really feels safe to do it within 2 months if the blood test and the clinical status of the patient is fine.
The next question is in Spanish. I will translate in English. You can answer in English, but you have a prerogative to answer in Spanish after as well, for the Spanish ladies. Dr. Burgos, do you recommend doing a gym with weights and cardio, or is it not recommended to exercise with weights?
There's absolutely no study that forbids any sports. Like we can try to find the logic in things, but there's no like specific rules proven. All right. So my advice is to do more like non-impact sports: aqua gym, aqua bike, swimming, yoga, cycling, and so on. But I don't think there has to be like a very strict restriction, because there's no study saying you cannot do muscle. One thing you need to know when you're doing like musculation is that maybe the perimeter is going to increase, but because the muscle is going to increase, but the fat layer is going to remain the same. So from my point of view, nothing is forbidden from the sports point of view, but my recommendation is to do sports in water because of that lack of friction, and because of the effect that the water has on providing a relief in the legs.
You can say this in Spanish as well, doctor.
Sí, perdona. Bueno, no hay ningún deporte prohibido. Puede ser que cuando uno gana un poquito de volumen muscular, la pierna gane, pero la parte grasa va a permanecer similar. Y se recomiendan más deportes en agua, aquagym, aquabike, natación, pero no hay ninguna cosa que esté especificada que no se deba hacer. ¿De acuerdo?
The next one is, how long is your waiting list?
How long is my waiting list? All right. So the thing is that We had the COVID situation. I was thinking of going on vacation. I'm not going to go on vacation, so I can shorten a little bit. I think it's around 6 months, 7 months, because we have increased the operation rooms per week with me and with my team. It's around 3-4 months. When my team is operating, usually I am in the next operation room. They never call me because they are very capable, but I'm there, and sometimes I just go and see everything's fine. Yeah, everything's fine. But yes, usually it's around that, like 6 and 4, more or less.
Thank you, Teresa.
Yes, so this is a question about secondary lymphedema, not in feet. Should the goal be to control the treatment before or after having lipedema surgery?
I think lymphedema needs a different approach. Like, indeed, liposuction is one of the options of treatment, but it would be the last of the options. And me personally, we don't treat lymphedema patients. Lymphedema patients would benefit much more of microsurgery, nose transplantation, anastomosis between lymphatic vessels and veins. So liposuction, it's an option, but it's not that used. And my belief is that it's better to try to find a specific doctor that works in lymphedema, like a specialization. I think it's key for this.
Yes, so but we also know that when you have lipedema, you can get secondary.
You mean but still, when, like, for example, you're speaking about stage 4, no? Then when there's lipedema plus lymphedema, so it's not like, because secondary lymphedema can be from a surgery, pelvic surgery, from radiotherapy. So if you're referring to a stage 4 lipedema, I still will recommend a patient, maybe a multidisciplinary assessment with special attention to solve first the lymphatic situation.
Okay, thank you. I hope that answered the question which was there. And then we are back to the hormonal changes. So your advice was to operate outside the hormonal changes.
Yeah, that's right.
But what is the advice for those in the late 40s who are approaching menopause, or anyone approaching menopause?
Mm-hmm. There's a lot of debate with menopause and with pregnancy also. So my advice is to operate before the hormonal changes come, because if we have this volume of fat and we leave it to evolve, it's going to increase a little bit, and it's going to stretch the skin, is going to provide a lot of volume, and my belief is better to operate before that, so we reduce the amount of cells, and when the hormonal change comes, there's going to be less cells that are going to be able to respond, so the increase is going to be much less. That's my belief. Having said this, before, like, for example, if a patient is 37 years old and asks me about pregnancy, I would say first the baby and afterwards everything else. But the general advice would be, I think most of the surgeons will think about this, would think like this. It's first surgery before the hormonal change, but this is also a very personal decision.
Okay, thank you. A third question here, and that is about you said that if you are able to walk you should be able to walk out from the clinic upon when you're getting released. But if you have some mobility issues before the surgery and are not able to walk before the surgery, how do you?
All right. I'm guessing you're referring if the patient comes in wheelchair so then we need to do like passive mobilization with a physiotherapist. All right. And also when the patient have a lack of mobility due to the inner part of the fat, which is located in the inner part of the thighs, just after surgery, they can even have some increase in mobility. All right.
Okay.
I'm going to put the blind stuff because I'm getting the sun. One minute.
Yes.
Thank you.
Teresa, I will take now, or you are taking?
That was the third, so you take now.
Okay, I take the group because we have quite a lot.
Able to see you. It's not that much fine, but at least.
We send you some clouds from London.
All right.
Dr. Burgos, I think you answered this one, but I will take it just to be on the safe side.
Right.
If a woman with lipedema is close to menopause age, is it better to wait for menopause and then do surgery?
My advice is do not wait more. The menopause is going to most probably increase a little bit the volume, but that is going to distend, stretch a lot the skin and provide bigger volumes. My advice is to go and do an intensive approach to leave a very thin layer of fat and afterwards the response to that hormonal change is going to be much less. But that's nothing proven. That's also like a personal opinion.
Dr. Burgos, is it safe for a person with RA and on biologics to have liposuction?
With what? With?
RA. RA is rheumatoid arthritis.
The problem with RA is the medication, which is immunosuppressant, the medication. We really need to speak with their rheumatologist to see if they are able to remove that medication for some time or not. And we will need to think thoroughly about that case. We need to speak with her about the benefit and risk, because the risk of infections are bigger in this status.
And what is the oldest person you can operate on?
The oldest you can is anything can be done, but the thing is that is it safe to do it? So the oldest person, I would say above 65 years old, we really need to have like some justification for doing this, like a lot of pain, lot of impairment, and still be aware that the risks are bigger.
Teresa?
Yes. So some comments on the long-term effects of WAL. What is the longest time?
I'm listening to you. I'm listening to you. You can keep talking.
What is the longest time you have followed up a patient post-op, and are the result of the liposuction long-lasting? The result
of the liposuction are not well known on the long term. Right? If we see that a follow-up, which is like 5 years, 10 years, that might be a little bit too early to see what's going to be the evolution of this, because if at least in our case, we remove big volumes. So the problem is when you leave like a big layer of fat. If you leave a big layer of fat, then it's more likely that this fat is going to cause problems in the future. So my advice is, like, if the surgeon who's treating you is a specialist in this and is able to remove big volumes with safety, is to try to be intensive and to be ambitious, because we still don't know about the long-term result of this.
Yeah, but do you think there would be a difference between WAL or TAL? We have seen studies on TAL.
Yeah, that's true. The main studies are on TAL, and I think the WAL are more is like a relatively like more new technology, not that much, but still more. And there's studies, but just very short-term studies. The using of WAL or TAL, both are safe. I think both are efficient, but from my point of view, WAL allows you to have a more detailed result, but still this is an opinion. And we still need to do like comparative studies, but these studies are difficult to do, because for doing a proper studies about this, you need to take 100 patients, do surgery, 50 to like randomly assign them to one surgery, do the surgery, don't let them know which kind of surgery they had, and then compare it. And this is very difficult, all right? So from the scientific point of view, comparing two techniques, it's difficult. Sometimes I feel that there's too much focus on the technique, but the most important thing is not just the technique, it's the surgeon or the team that does this technique. So you can have WAL technique, and that doesn't make you like to have the best results, or you can use TAL. And so the main point is person who's using that technology to make it safe, to make it ambitious, and from my point of view, WAL is better, but still I've seen fantastic results with TAL.
Yeah, Dr. Burgos, at this point, allow me to say that the people who do the research, don't forget that these people are treating lipoedema since 2002, and it was different periods. So it was new at the time. So they just put the effort to do the research, and that's why these long-term results exist today, because it went from, in the same clinic, the father continues with the stepson. So, and that's why they follow it. We don't have any other studies. You are right. And to do a study, it requires a lot of
time and effort. Yes,
and you need people to follow these patients, and the patients willing to report back.
That's true, because
so
one thing that...
Yes, and what I can tell you from my humble experience as a group owner, people disappear after they do surgeries, and it's very difficult. And I can tell you this research maybe can happen in a very disciplined nation like Germany, where they go back.
Yeah, the thing is that it's, as you said, like most of the patients after finishing the Lipoedema treatment, they disappear. They don't want to know more about this condition. They don't want to, it's been like a lot of suffering. So it's like, just leave it behind, all right? Yes. But it's true that, and I think it's Hanse Clinic who's done this research, yes. and it's a fantastic job. It's a very difficult task to get feedback back, because in our case, and the feedback is usually by phone or by mail, but it's difficult to ask all these women to come back to see them just for a test or for a study. So I agree with you that there's a lot of effort put on that study, and I really congratulate that team for that, because it's very difficult. And I find myself, when I try to gather information, they literally, they don't answer the emails. They don't answer it.
Yeah, I see it in the group. They disappear. They don't come back to show to the others their long-term results. They just don't want to be associated with the disease any longer. This disease affects us mentally, affects us in many ways. So I understand people, they want to disassociate. Yes, Teresa? Thank you, Dr. Burgos.
Also, wait 1 minute. I think it's also important that at a certain point, the patient disconnects a little bit of all this lipedema, especially in the early postoperative period. Like sometimes the Facebook groups and the WhatsApp groups, they make the patients a little bit insecure, more worried. So I sometimes ask certain kind of profiles of patients to just disconnect, focus on the recovery, and afterwards they will have time for all that. But sometimes that has influence in the recovery, and they make them worry without reason or being like very anxious. So certain kinds of patients with like a lot of anxiety and previous depression, is good just to focus on the recovery, on your relative, on the physiotherapist, call your doctor when you need somebody, and be relaxed about the postoperative period.
Yeah. Yes.
Yeah. I really second that. So the next,
I keep hearing you, but this is horrible.
How do you know which part of the body that should be treated first? Lower legs, upper legs, or arms? Right. And how do you decide how many surgeries are needed? And when do you decide that in the process?
All right, I think this is fine. No more changes. All right, so this is a decision that needs to be spoken with the patient. So when the patient has low legs and arms, very clear symptomatic arms, I prefer to start with the arms, because it seems it's not clear that when you address first the legs and you remove a lot of volume from the legs, in the arms, then there's some sort of increase. Sometimes it can, maybe it's not a real increase. It's like a comparative. You see the arms, the same shape. You see the legs, they're very thin. And it can be like visible. But sometimes the patient, they really feel that there's an increase in volume and the clothes don't fit in anymore. So if we start from the arms, then we can reduce volume. In the arms, the skin is not going to be stretched. If we start in the legs and there's a response in the arms, the skin is going to stretch a little bit. That's one idea. And about the legs, we usually start in the lower legs, because if we start in the upper legs, sometimes that edema is going to fall into the lower legs. So that's maybe it's going to make us wait, instead of 7-8 weeks, 9 to 10 weeks. Having said this, some patients really benefit from starting in the upper legs, because either they have much more pain in the upper legs, or they have difficulties in walking due to this friction with the inner part of the thighs. So if you treat first the thighs, that's going to give the patient much more mobility for the next surgeries.
Okay, thank you. Patricia.
Patricia is back. Patricia is Spanish.
Hi, hola, buenas tardes, doctor Burgos, ¿qué tal?
¿Cómo estás?
Bien, bien, bien. ¿Y usted? Bueno, we have a question from Shelina, and she says, I appreciate your acknowledgement of the impact of this disease on mental health. I have read that liposuction and similar procedures can have a significant impact on an individual's mental health, both good and bad. In your experience, do you see that with lipedema patients specifically as well?
If I feel there's an improvement after surgery on the mental impact of the impact,
that liposuction has an impact, yes, on mental health.
But it's not only the liposuction. It's the impact starts the moment you get a diagnosis. That's why it's key to get an early diagnosis, and also on the long term, like the patient, sometimes they really feel they are a different person. They change completely their wardrobe. They have to throw away all the clothes. They start to wear different clothes. They start to even the husband or the wife, if it's they feel that there's like a real change in the anemic status, in the emotional status, in the way they relate to others. Sometimes, as I said, there's some difficulties in accepting this new body. Sometimes, maybe, for example, the patients, the knees, they touch each other bone to bone, and they get surprised because they haven't had that feeling before. And it's also a process to accept this. It's also important, we know that the result is good, but it's not perfect. This is key, because Instagram is very harmful as well. And the patients, very frequently, they compare to others that maybe their case is completely different of the other one. And the case, the result really depends on also really personal aspects, the age, the recovery of the skin, the volume, the muscular volume. So my advice is never to compare too much to other patients. Also, in the groups, or that's why they told me there's some fight about the liters. No, my surgery was 5 liters. No, mine was 6 liters, which is better. It doesn't work that way. So the more liters doesn't mean best surgery. Some patients, they really want to know how many liters are you going to remove. And my answer is the liters you need. So the most important thing is not the volume you take out, is the volume that stays and how it stays. So it's really not a good measure of the quality of the surgery if you need more liters to be removed or not. You really need to adjust to that patient.
Patricia.
I cannot hear you.
I'm mute.
Sorry, yeah. As I was saying, thank you, Dr. Burgos. And next question says, what is Dr. Burgos' opinion of skin tightening? Does he offer any after liposuction or with the liposuction?
My advice is to separate these processes, because like a thorough liposuction has a postoperative which is intense. The skin is not in its best moment. And my advice is to defer that skin tightening. One patient seen at 3 months after surgery, it really looks as they're going to need skin tightening. But maybe that same person 1 year after, the process of recovery has go through and improves a lot. What can we do to help like the skin recovery? Vitamin C, collagen, swimming, aqua gym, and also radio frequency seems to be able to tighten a little bit. Having said that, big volume patients with like very preoperative flaccid skin, if they're gonna need skin tightening, they're gonna need it, no matter what you do. So my advice is to wait 1 year to that to do that skin tightening, and to find a really good specialist in skin tightening procedures, apex procedures, and so on.
Great, thank you so much. And next question. For patients traveling from abroad, how long do you suggest to stay in Madrid?
All right, so my advice is to stay at least 10 days. Well, if the patient comes, like flies business, laying down, maybe from long distance flights, maybe we can adjust it to 8 days. But for two reasons, we need to wait some days. First, the increase in thrombosis risk. We really, even though we provide heparin to prevent this from happening, we really need to reduce that risk. And second, because imagine if you have a problem while flying, you make to take down the plane to turn down, or maybe you feel dizzy or so. So the first days, I don't recommend the patient to fly. At least I would say 10 days of stay. And also, if they come to Madrid, the MLD, the manual lymphatic drainage after surgery, can be done in centers that are very specialized in lipedema surgery, right? For concerning MLD, that I didn't speak about that, my advice is to have 3 MLD the first week, 2 per week for the first month, and then depending on your therapist. Which kind of MLD? The ones, more or less the same that are used in lymphedema. Godoy technique, Voder technique, Leduc technique. No, it's not like hard MLDs. It's like very gentle MLDs.
Perfect. Thank you so much.
Okay. So we have one more question here. How can you best avoid bumps and loose skin after surgery?
All right, bumps by the adequate technique of rechecking and rechecking and rechecking and be detailed and be detailed and be detailed. That's the way you can avoid like bumps of fat. Skin loosening sometimes is unavoidable. Even using different techniques, if you have a leg like this and you're going to leave it like this, the skin retraction capacity is what it is. So there's a certain point that the skin, especially in the inner part of the thighs or around the knees, if the thighs is going to fall into the knees, there's going to be some looseness, but it really depends on the patient. We can really not predict sometimes who's going to need some more procedures and who doesn't, or who won't, because it really has a very individual effect, and sometimes it's very surprising how the skin can react after surgery.
Okay, thank you. And this is a question, I read it just as it is. One of the things that concerns me most about lipedema is the inflammation. Have you seen C-reactive protein levels reduce in your patients after surgery?
The problem with the levels of PCR is that they vary a lot in between the laboratories. Sometimes we see that it's rising, it's abnormal, but very frequently we see it normal. So I cannot really give you an answer on that, but we really know that there's a background of inflammation in this condition. That's why anti-inflammatory food helps a little bit. I cannot give you a lot of feedback on that because I really don't know.
Yeah. Okay. Can you say if there is a difference in result if a patient uses deep tissue massage, gua sha, or facial blaster before surgery?
Preoperative treatments, I don't know how much they work. My advice is to have 2 MLDs the week before surgery to reduce a little bit the edema, but there are no serious studies about the effect of therapies before surgery. This surgery is expensive. It's a big economical effort. So if it's not proven, I don't think it's good to try and do that expense just because somebody told you. Like we need like something like more certain.
Yeah. Okay. And you spoke about the MLD post surgery, but how soon after the surgery can you have other types of massage and use vibration plates, etc.?
I don't really feel that vibration is going to help that much or any. I won't recommend that. I would say MLD from 48 hours after surgery. That's my advice, to keep it 2 per week and then hear what your therapist thinks. If you need 1 per week or none. But vibration, I don't think it gives any advantages.
Yeah. Okay. Thank you.
Dr. Burgos, how much time do you allocate to us? Because we have some more questions.
I have plenty of time.
No, because I know it's you're tired working all day, so please be patient.
I'm more than happy to, but Maria, I'm more than happy to be here, and I can be here at 10. I have to go and take my wife somewhere, but until 10 p.m. here.
Yeah. No,
but 10 Spanish time, so I have anytime.
We see more joining and asking people. They don't leave; they are just still there listening. So it's
that's good.
Patricia, please take the next 3.
Yes, we have more questions. Question for Dr. Burgos: will he treat a patient who attends surgery on her own?
We have had patients that came on her own, but they hired someone to be with them. Like, you need to imagine that the post-operative period, it's a process which it can be intense, and you always prefer to have someone. What happens if you get dizzy at some point when you stand up too fast? Won't recommend it. Can be found somebody that can take care of them, like a nurse they can hire, but and to fly alone is not the best idea.
Perfect, thank you. And on the same sort of question, can the partner or relative stay overnight with the patient?
For sure, yeah. I cannot guarantee they're gonna sleep a lot, but they can stay. And I think it's good to stay because it's someone that you love, who supports you. The patient has like a button. Anytime they press the button, a nurse is coming to check on her. It doesn't need to stay, but I think it's good that they stay.
Good. And my last question for now, do you do liposuction on the buttock, tummy, and back area?
We do onto the hip, like the ankle to the hip. The abdominal area, we don't do like a specific treatment of the abdominal area, because that can be treated with other options such as Vaser. All right. Sometimes if we feel that there's very fibrous nodular fat and we still have volume, we haven't reached like big levels, we can reduce a little bit. But this fat in the belly, most of the times it really responds to exercise or diet. But yes, we treat the buttocks area, and we ask about what is the preference of the patient.
Good, the buttocks, yeah, good, because we get that question a lot.
Yeah, because if not, it's going to look very strange. Like the legs very thin, and then the buttocks. No,
indeed,
it won't be a good idea.
Perfect, thank you.
Yeah, I think I will, because the next question is also about lipedema in the stomach. We can read new scientific articles which says we can have lipedema in stomach. What do you think about it? Have you already done surgery in stomach? There's
an article on Karen Herbst, I think, saying that can be almost everywhere, but it's not very well, like it's except in the hands and in the feet. But I don't think it's something very well established, and usually there's no symptoms in the belly fat. So we don't really know if it's lipedema, or because frequently on the follow-up we see how the patients, they reduce volume of the abdomen, and this is not like the typical lipedema behavior.
Yeah. Okay. Thank you. We have a question in Swedish. I will translate it.
Sometimes I get messages on Instagram in Arabic, in Russian, and sometimes it's difficult to me to say. Please know that if you comment on a post, you cannot copy paste. So sometimes I just really don't know what is there.
Yeah. So if not all the fat are taken away from the legs, is it and there are some lipedema fat left, is it possible that you will need additional surgeries in the future?
Possible, yes. Probable, we try that is not probable, because of course you need to leave something. You cannot just leave it because it doesn't look beautiful, and also it's dangerous. So you need to leave a certain layer. And that layer depends on the patient and of the choice of the patient. If an area has been treated, can you treat them? Can you treat it again? Yes, you can. And indeed, like I would say, like 1/5, like 20% of the patients we treat, they have had previous liposuctions in different areas. So it can be done. We try that we are ambitious, so this doesn't happen. But we sometimes cannot know what's going to be the evolution, because the life is very long. And if you operate on a patient which is 20 years old, there's going to be pregnancies, menopause, and we try to make it like ambitious and long lasting, but we don't know about what the result is going to be.
Okay, thank you. The next question is about shaping of the legs, and appreciated that you talk about it. And what areas are most difficult to shape? Do you focus equally on the whole legs or specific areas?
I would say the knee, it's very delicate to see the kneecap, to see like the knee area is difficult and it's challenging sometimes, and it's really fibrous sometimes. So the knee area, I would say, like is like the most difficult area. The more delicate area is the forearm, but the more difficult one is the knee.
Okay, thank you. Patricia?
Yes, if there are some vein issues in the legs as well, should a woman with lipedema take care of the veins issue before liposuction, or is it okay to do liposuction first?
If the vein is just a vein insufficiency, like in the Doppler, they see just a mild insufficiency, that's fine. The problem is if you have varicose veins, like of importance, like where you need to know that the veins and the surgery are in the same area. So if you have dilated veins, which are very fragile, and you are working in that area, this can cause big hematomas and so on. So we prefer them to have them treated before, or we need them to have them treated before we do our treatment.
Perfect. Next question. Does Dr. Burgos treat lipedema on lymphedema patients?
I think I already asked this.
Okay, sorry about that. I got late.
All right.
Perfect. And just bear with me for a second. What is the maximum amount expressed as a percentage of the body weight you remove during one surgery?
All right. So there's a lot of talk about this. There's the limit spoken as the most is 10%, and sometimes we stay from 6 to 8%. Is the 10% something like law? I don't think so. Like if, for example, you have a 120 kilogram patient and you already had one surgery in which you removed 12 liters, can you, and the recovery was fine, in the second surgery, can you do 12.5? I think yes, but it really depends also on the way the extraction is done. Like if you see that the fat, some fat, like we need to know that every patient is different, and there are some patients where the fat is like just very soft and very easy to remove. There's some patients that is medium. There's some patients that the fat it's hard. And some patients just, I would say, less than 3%, which is like a rock. And it's like, and those are dangerous cases. You really need to have a lot of expertise in this. So if the fat is like a rock and you use the pressurized saline solution to make it soft, but still you need to make a lot of effort. All right. So if you find that kind of fat, of course, you cannot surpass the 10%. If you find that the fat is very, very soft and it's very gentle, the way that it's moving, absolutely not that much bleeding, you can maybe be around that limit of 10%, knowing that the more volume you remove, the more anemia you have, the percentage of transfusion can increase from 1% to above 1%. There can be some hydroelectrolytic changes, hypopotasemia, hypercalcemia, hyperpotasemia. So, but the standard is to stay between 6 and 10% of the volume.
Perfect. Great. Thank you. And
so, sorry, sometimes the area you treat is not, the limit is not the volume, it's also the time. For example, for doing properly the lower leg, like properly in really detail, the lower leg area, sometimes you need 3.5 hours. So it doesn't make sense to keep operating and do the full leg, because that's going to take like 7 hours, and that's not a good idea. So, and also the area treated, it's area that's producing edema. So if you treat a very huge area, there's going to be a lot of production of edema. That's why we frequently split surgeries depending on the patient, between 2 or 3 surgeries for the full legs.
Great, thank you so much. And there's a lady that wants to know, she had operations with WAL and then TAL and PAL techniques, but she says during recovery she experienced much more pain after each of the WAL operations. If you know, if you have an explanation for this.
But which areas were treated? Because
she doesn't mention.
Because sometimes
lower legs.
Because lower legs are the more sensitive area, and the recovery in the upper legs is different from the recovery in the lower legs. The lower legs is like much more discomfort, sometimes pain that you need to control with analgesic. The upper legs is not that painful, but it's very tiring. It's very like if a patient that feels that they go to the toilet, they go to the kitchen, and oof, I need to sit. So there are different types of post-operative periods.
Okay, great, thank you. And I think it's back to Teresa now.
Back to me with a French question.
Okay.
There is, the lady is asking, is it dangerous to transfer lipoedema fat in another part of the body? Because it's a sick fat, she says.
From the theoretical point of view, in my opinion, it doesn't look like a good idea. But I know there are surgeons that are putting lipoedematous fat on the breast. I don't know. I don't really know. I don't know if what's going to be the behavior of that. So I cannot recommend it, but I cannot forbid it because it's something that is not known. If I'm going to use like a fat transfer, I prefer to use like a normal unill, not ill fat, but still it's a little bit unknown, that topic.
Teresa?
Yes. Is the operation easier or harder on a patient when she has lots of muscles? Are there specific recommendations to better prepare the operation in that case?
No, like the muscle is in another plane. So if this is the muscle and this is the skin, we are operating on this area here. So it's not going to affect that much. In fact, if it's a very healthy, sportive patient, most probably the recovery is going to be faster, but it's not going to really change the operation. Maybe it's going to affect the final result. So if the muscles of the calves are very, very, very big, that's also that's going to have some impact in the final result, because what we treat is the fat, but the shape also depends on the muscle. So that is going to have some influence in the final result from the aesthetic point of view.
Okay, thank you. And you mentioned vitamin C and collagen for skin improvement. Should you take these supplements or via IV?
We recommend them to take them orally after surgery 2 months, but vitamin C, we ask them to take them in a liposomal formula because it's absorbed better. But this is also very theoretical. It hasn't been proven, but it really, there's all studies in other fields that they say that it can help the collagen production. But as it doesn't produce any harm, after starting using it, we feel the feedback is positive about it.
Okay. And what supplements are good to help to boost the collagen?
They're different, like different brands in Spain and in like the collagen. The recommendation is more limited. All right, and I could not tell you like a specific brand. Here in Spain there's one, and most probably in France there's another one. So there are different options. Yeah.
And do you ever do just one surgery, or is there always at least two?
For the full legs, or you mean for? I would guess so. No. So for if the lipedema is affecting from the waist to the ankle, my belief is that one surgery is not enough, and we need to split in two surgeries. Another thing is that you have affected the calves and the lower legs, and a little bit just in the front thighs. That can be done. Yeah, we can push it a little bit further, and we can do it. Or your main affectation is on the thighs, but you have like some balls just below the knee. We can push it a little bit to make it that. But if there's a full affectation from the ankle to the waist, my belief is that two surgeries are needed.
Okay, thank you. That was the last question in the chat.
I have some more. I have some more in the group.
I
About?
have many.
Yeah, there's plenty.
That's fantastic.
What about using Vaser in liposuction?
Vaser, well, we need to know that it has to use tumescence, like first tumescence and then Vaser. It's an option, but from my point of view, for lower legs and upper legs, WAL provides a better result. But that's my opinion in my hands, having tried different techniques. Vaser can be an option if it's used with a lot of tumescence first.
Yes. Okay. Someone insists about flight and stays in Madrid. What about flying when the flight is only 50 minutes?
50 minutes, 50.
Yeah, 50, less than an hour.
I don't recommend it. Like it's very uncomfortable. If the flight is 50, unless they're on an island, they can go by what the people from France do. They take a fast train the next day after surgery or the 2 days after surgery. They take a fast train Madrid to Barcelona, and the fast train, which is 2 hours, Barcelona to Paris is 5 hours. Or they rent a car in Barcelona and they drive from Barcelona to that area. If they are living in Sicily, then we have a problem. But still, my recommendation is to wait, for safety reasons, is to wait at least 10 days.
Okay. Yeah, I think it's understood. Someone wants to ask, do you carry out video consultations or only face-to-face on patients who have been diagnosed with lipedema?
Very important question. Well, there are patients that can be diagnosed with video consultation. My belief is yes. So that there are patients that cannot be diagnosed by that mean. So if you have a patient that has clear symptoms, all the spectrum of symptoms, lack of response to diet or exercise, we ask them to send us 14 photos in different angles, seeing the morphology and so on, and we see that there's a clear disproportion between the torso and the legs. The feet are free of affectation. There's a calf sign. There's a shape. It's and sometimes even they have a diagnosis of lipedema. Their diagnosis. It's very, very clear. However, if we have a stage 1, mild symptoms, not very clear morphology, that's not, you can have like the intuition that it's lipedema, but you need to confirm it presentially. All right. So there are cases that, or for example, if there's a big overweight, sometimes it's tricky. So W's case, I prefer to see them face to face. Well, I have to see them face to face. Very, very clear case with all the criteria. I think they can be diagnosed by video consultation. Yes.
Good. Great, thank you. And in regard to this question, do you have an idea of what the fat is going to be on examination before you go into surgery? You were discussing some people have harder fat or more fibers or have softer fat. Can you assess this externally?
Sometimes yes, sometimes not. Like sometimes you touch it, especially when it's very soft, and that's clear. But when it's firm, sometimes it's firm on touch, but then when you get inside the cannula, is very soft. And sometimes when it's more or less firm, it's like sometimes it's like rock. And another tricky option is that it's like bubble gum. So it's like plastic, but it won't come out. So you really don't know it until you have the cannula inside, and then you adjust the time, the approaches, the checkups to that kind of fat. So you really need to adjust to the fat, but it really doesn't make a difference from the technique point of view or the device if the fat is going to be fat or hard. Maybe that day you're going to arrive home more tired or less, but the technique is going to have the same principles, the same safety points, and most probably if the fat is hard, the post-operative period might be a little bit slower. All right, and also there's a lot more important to moisturize the skin a lot after surgery. Many times with the compression garment before surgery, we achieve to make this fat softer, and that makes that the surgery is easier. Sometimes when we go for surgery, we ask usually the patients to wear the compression from 4 to 6 weeks before surgery, all right? And maybe we go and it's very hard and it's very, and you arrive home very tired, and the next day the patient, you tell her this, and she said, yeah, I didn't use it that much. So sometimes it's related, sometimes it isn't. So I operate a cousin from me, and I saw her 6 months with the compression, and still it was like one of the hard cases. So yeah, it can vary.
Perfect, thank you. And we have 2 more questions.
Anyone do
Can liposuction fatty and sorry, I think it was not correct. Oh yeah, if you can do liposuction on fatty and swollen flesh around the ankle bone without damaging the ligaments.
To damage the ligaments, you really need, you really want to try it to like, it's difficult to damage the ligaments if you dominate the technique and if you are familiarized with lipedema. The problem is if you are not aware that it's a lipedema case and you are trying like conventional dry technique there. It's difficult to damage a ligament. Ligaments are very hard, and also you are, with the other hand, you're very like feeling and touching, and it's going to be very difficult unless you want it or do it on purpose.
Okay. And the last question, have you experienced that a patient got lymphedema after having liposuction for lipedema?
Not in my case. I've seen secondary lymphedemas after dry conventional liposuctions, yes. But I think that with a good tumescence or good WAL technique, we still haven't had any case of that, and it's not that easy to have that. Another thing is that there's like some lymphedema secondary, like of what we spoke about, like stage 4. But usually, I think that this technique is specially designed to preserve the lymphatic vessels.
I think, Patricia, there is more.
No, I've managed to the very bottom, and I don't have any more new things. But let me just I've refreshed the page.
Do you, Patricia, have a question yourself?
No, I don't have.
I will take this question, Dr. Burgos.
Oh, yes.
What would you recommend to a patient with rock hard fat whose arms had already been operated 2 or 3 times, but who still has fat left around the wrists and the elbows?
We need to know if this fat is symptomatic or not, because if she already had 4, 5 surgeries, 3 surgeries, the more you go that area, the more difficult it's going to be. So we really need to balance the risk and benefit. If the wrists are very painful, or the elbow is very painful, we might consider to have another surgery, but the risk is not the same as if we had the operation at first with a delicate technique. So I cannot tell you for sure. We need to know more about the symptoms, but what does it mean? If it's just a cosmetic benefit, what we are looking for, we need to check how hard it is to make like a balance and be clear with the patient, you know, like the risks are this, the possibilities of improvement are those. What do you think, and what do we think as well? Because we cannot operate everybody just because the patient wants. We need to be sure that the first in medicine, the first step is not to produce damage, and then to try to improve it. So if we feel that we're going to take too much risk, maybe we won't recommend another surgery there.
And Dr. Burgos, how long after the video consultation can the first operation occur?
Well, we first need a Doppler ultrasound, which says that there's no varicose veins. We need that the patient start looking for the compression, and it can happen if she has the compression on and already for some time, and there's like a spot which is open. It can be like fast, as long as they can come to Spain without this COVID situation. But usually it's 6 months for my patients, for 3-4 months for the patients that have operation with my team usually.
So you don't take a patient if they don't wear the compression?
No, because it doesn't make sense. They're gonna need them after surgery, so it's important they get used to this. Because at first, one advice is please get gloves, because the fingers get hurt. So get gloves, maybe gardening gloves to use them. There's some devices that provide like some sliding, which is like what is called the easy slide. They're very helpful, and they provide it's much easier to put them on. And also we usually need that reduction in swelling. We need that softening of the tissue as well.
Yeah.
It's hard to look at as a ghost with this slide, but let's continue.
Fantastic, Dr. Burgos. Don't worry.
There's more questions. I will not say it's the last one because I will not. We have seen the skin ulcerations after WAL Lipedema surgeries. Do you know why this happens?
WAL ulcerations have a combination of factors. Ulceration usually occur in the lower legs because it may occur in very hard cases. Because to remove that volume, you need to go in that area many times. That leaves the skin very sensitive. Also, there's another factor, which is the edema that is produced and compresses the skin from inside. Also, there's the compression garment make compression from outside, so it's like a sandwich. And sometimes also there's some wounds that are caused because of the friction of the compression, especially in the ankle, in this area here. And additionally, the patient doesn't have a lot of sensitiveness. So if you have a shoe that is hurting yourself, you realize made one. But if you don't have sensitiveness and the compression is hurting yourself, you don't realize that. So every day, my advice is to look at the legs and preventively moisturize them with moisturizing cream, special oils, and to prevent this from happening.
Great. And I think, Maria, now we have arrived and there's no more. I mean, I've just literally just refreshed.
No, refresh, there is.
No, but I have the last question. Okay, I've done it just now and I don't see more questions.
You can tell them, Maria, to tell them.
No,
Valeria.
I want to know if you have answered this, maybe because I was controlling the meeting. Do you always require for surface varicose veins to be treated before surgery, even if ultrasound on legs show deep veins are perfect and no venous insufficiency?
All right, so if they're like spider veins or reticular veins, those are fine. But if we have truncular veins or veins of big caliber, which is differs in one area or another, we prefer them to be treated before surgery to avoid the risk of big hematomas.
Mm-hmm. And then we have one in Spanish.
Yep.
Yeah, and I'll say, do you want to say it straight in English or in Spanish, because maybe she doesn't speak English, or?
Yeah, but it's for us to know what she wants to, what does she ask?
She's saying, maybe you can ask if he feels that lipedema patients, we have to educate our GPs, or médico de cabecera, that have no idea about this illness and they think we're making it up. And if you have something to suggest us to tell them.
Absolutely, absolutely. So we need like awareness and awareness and awareness, but it's true that sometimes the patient goes to the GP and the GP, they don't trust them. They don't feel that this is real. It's something invented by a surgeon to operate on the patient. So what we've done is in our website, we have put links to like 50, I think it's 15 international articles, 3 guidelines, and the international, the ECD, the international WHO classification. So when the patient finds these difficulties, they go to our website, which is open, of course, and they print like I think like this, and they come with all those papers, and then the GPs, they don't know how to react sometimes. So there are usually 2 kinds of GPs. There's the GP that reacts trying to learn about this and like, well, you know what? Let me look it up and see if this is real or what. This is interesting. Let me investigate a little bit about that. And there's the GP that says, I don't. This is an invention. So my advice with that second GP is to change the GP. But for the first GP, like I think like most of the GPs are like the first type. They see, oh, so this is a condition, and I don't know about this. Let me read about this, and we see each other in a week. But it's true that it's sometimes difficult to, and the average of doctors that the patient has seen before coming to our consultation is 5: GP, vascular surgeon, internal medicine, GP again, vascular surgeon. And surprisingly, the patient has got like an auto-diagnosis because she's seen herself in a picture or in a blog or in a group as yours.
Yeah.
Well, sorry, Maria, do you have something particularly in Spanish that this girl, particular girl, can show to her GP?
Yeah, but it's much more effective if they are in English because it looks much more international. All right. So my advice, but just tell her to send me a message through Instagram, and we will send her anything she needs.
Fantastic. I will tell her that.
We are closing, I think, with 2 things. I don't want the Lipoedema patient to be anxious, Dr. Burgos, because you have a reply to her email. Please take the name Marie-Hélène Boras. She's becoming anxious because she didn't receive a reply yet.
But the thing is that I have to say that in the last days, maybe because of your group post, we have received many inquiries. So we have 3 people replying to this. So I asked to have some patience about this. And also sometimes what happens is when we send a reply, it falls into the spam folder. So tell her if their filter is very strong, sometimes they can fall into the spam folder. So just tell her to write us again, and we try to handle this as fast as
I
possible.
think that Marie-Hélène Boras is watching you right now, so she listened to what you had said. And I will close with the final thank you from one of your patients, Natalie Hanks.
Oh, fantastic.
Natalie, she says, I don't have questions for Dr. Burgos. I just want to say hello. And thank you, Dr. Burgos, for giving me back my mobility. You are an amazing doctor. You're an amazing speaker and doctor, Dr. Burgos, today. We thank you very much. I think that after this video meeting, we will ask all those who have inquiries to watch it and not sending you emails coming directly for operations, because you answer all the questions
But
for A to Z, what they need to do. So I think they should start preparing the compressions, the things, and then come all the way to Spain. Todos seguidos.
All right. So I just wanted to thank you, Teresa, Patricia, and yourself, because it's been fantastic to share these moments. I'm more than open to any further activities or congresses. We're gonna see each other soon with the French Association in October. I think it's key we keep working on this direction of raising awareness, of convincing doctors that this is real, of speaking to our relatives so they know about this condition. I thank Natalie for her thankfulness. It's really a pleasure to receive patients from abroad. We really try to feel them so they feel very comfortable and like taken care of. And thank you for all the people who's watching and who's. I'm sorry that my English is not perfect, but I'm trying to.
It's excellent.
To improve it, and we keep in touch. And if you send if you have any inquiries or anything, you can send it by. I handle my own personal Instagram. Sometimes it may take some days because my wife gets angry if I'm all the nights answering questions, but it can take 2-3 days for answering. But I think I almost always reply. And thank you all, and thank you, Maria, for inviting me.
Dr. Burgos, it's a pleasure. I will leave the last word to Kate Foster, from board member of Lipoedema UK, because they have information about the papers you say about GPs, how they educate the GPs in the UK. Kate, you can speak to Dr. Burgos.
Thank you, darling. Yeah, we have some specific information in the UK. There's a training course that we put together for general practitioner doctors, which people can find out about on our website, lipedema.co.uk. And that training is hosted by and accredited for continuing professional development by the Royal College of General Practitioners in the UK. So people who want some information to give to a doctor can find that helpful. And that training can be done by doctors outside the UK as well as UK physicians.
All right.
So that's something that's quite useful, at least to make people aware of as a model. And there's some other information on our website for people who are trying to get information for clinicians. And we do have a professionally printed pack we can send out to members as well. Both in the UK and international members, if somebody wants some copies. So if there's anything we have that's useful to you, doctor, we're very happy to supply some of our materials for your international patients, if that's useful.
All right, so that's fantastic initiative. I will spread the word about this, because this is, I think we should have that in Spain, because that is marvelous. So the basis is to educate the GPs, because that's the start of everything. So congratulations on that initiative, because it looks very good.
And a few words on behalf of the French Association. We have Sarah this time.
Okay, so Ophélie had to leave us, unfortunately, so I'm going to speak in the name of the French Association. We wanted to thank everybody here tonight, especially you, Dr. Burgos, and everybody speaking. We will have the translation on the French Facebook page by Saturday. I took about 18 pages of notes, I think. And well, thank you, everybody, for everyone's help.
And from me and the Global Lipoedema Awareness Group and all the ladies watching, we thank you, Dr. Burgos. We thank everybody for participating. Thank you, Patricia, Teresa, French Association, Ophélie, Sarah, for your time today, but especially Dr. Burgos. We are grateful, and we hope this information today will enable us to support our global lipoedema community further. Thank you again, and hope to have you in the near future again for another session, maybe with other doctors, because this is the objective, is doctors get together, patients benefit. Patients get together, doctors benefit. So we want to have this two-way communication together to exchange information, because we as groups, and especially the global group, is a patients group. There you can read, you can write books through the information that is flowing in the group from the various patients. So it's very useful to have this, and I always, I know you are open. I know, Dr. Burgos, you are always there for me. Any time of the day I send a message, you always reply, and you are very supportive. Thank you very much. Good night from London. Good night. Ladies, stay to continue our chat. Kate, you want to speak? You want to say something to Dr. Burgos? No? Okay. We always stay after the meeting in order to continue our conversations. So we let Dr. Burgos go to his lady.
Muchas gracias, Dr. Burgos.
Buenas noches desde Londres. Nos vemos en Madrid.
Adiós.
Adiós.
Que tengas buena noche.
Hasta luego.
See you. Have a good
Adiós.
night.
Thank you. Ciao.
Bye-bye.